Sometimes the most dangerous people in a room are the ones nobody notices. They blend into the background like shadows, their true nature hidden beneath ordinary uniforms and gentle smiles. Sarah Mitchell looked like any other nurse on the cardiac wing of St. Mary's Hospital. Scrubs slightly too big, hair pulled back in a practical ponytail, eyes that seemed to avoid confrontation. Her colleagues saw weakness where there was actually restraint, mistook quietness for incompetence, and assumed her reluctance to share personal stories meant she had nothing interesting to tell. They had no idea they were making fun of someone who had once carried wounded soldiers through enemy fire in Afghanistan, someone who had earned commendations that most people only see in movies, someone whose phone number was still in the emergency contacts of Navy commanders across 3 continents. Sarah had traded her combat boots for nursing shoes, her rifle for a stethoscope, but some transformations run deeper than others. When you spend years being invisible to save lives, it becomes second nature. When you learn to move through chaos without making a sound, civilian life feels strangely loud. And when you've proven yourself in the most dangerous places on Earth, hospital politics seem almost laughably trivial. Sarah Mitchell had survived things that would break most people, but somehow, facing the daily cruelty of workplace bullying felt like a different kind of battle altogether. What her colleagues didn't understand was that some battles choose their own timing, and some warriors know exactly when to reveal who they really are. Sarah Mitchell pushed through the glass doors of St. Mary's Hospital at exactly 5:45 in the morning, 15 minutes before her shift began. The early November air carried the promise of winter, and she pulled her worn jacket tighter as she walked through the nearly empty parking lot. Her footsteps echoed against the concrete, a steady rhythm that reminded her of boot camp marches from what felt like another lifetime. The hospital's fluorescent lights cast everything in that familiar institutional glow as she made her way to the cardiac wing. Sarah had been working here for 3 weeks now, long enough to understand the unspoken hierarchy, the gossip chains, and the way certain people looked at her when they thought she wasn't paying attention. She kept her head down as she passed the nurses' station, where Jessica Hartwell was already holding court with 2 other nurses, their voices carrying that particular tone that meant someone was about to become the subject of morning entertainment. "I swear she doesn't say more than 10 words per shift," Jessica was saying, her voice pitched just loud enough to ensure Sarah could hear. "Yesterday I asked her about her weekend plans, and she just mumbled something about reading. I mean, come on, who reads on weekends?" Sarah continued walking toward the break room, her expression unchanged. She'd heard worse things about herself, usually while crouched in a foxhole or during mission briefings when commanders thought female medics were a liability. The difference was that back then, she'd proven them wrong with actions that saved lives. Here, she wasn't sure proving anything was worth the effort. The break room was empty except for Margaret Torres, a veteran nurse in her 50s who'd been working the cardiac wing for nearly 20 years. Margaret looked up from her coffee and nodded at Sarah, one of the few gestures of basic respect Sarah received during her shifts. "Morning, Sarah. How are you settling in?" "Fine, thank you." Sarah poured herself coffee from the machine that probably hadn't been cleaned since the Clinton administration. The coffee tasted like it looked, but caffeine was caffeine, and she consumed far worse during 18-month deployments. "Don't let them get to you," Margaret said quietly, glancing toward the door. "Some people here think being loud makes them important. They'll find someone else to pick on eventually." Sarah appreciated the kindness, but Margaret didn't understand that being picked on wasn't the problem. The problem was the constant noise, the way people seemed to think every thought needed to be shared, every emotion broadcasted. Sarah had spent years learning to be quiet, to observe, to move through spaces without drawing attention. In combat zones, noise got people killed. Here, it just got people promoted. Her first patient of the day was Mr. Rodriguez, a 68-year-old man recovering from triple bypass surgery. He'd been in the ICU for 4 days and was finally stable enough for the cardiac wing. Sarah reviewed his chart as she walked to his room, noting his vitals, medication schedule, and the fact that his family had been practically living at the hospital since his surgery. Good morning, Mr. Rodriguez. I'm Sarah. I'll be your nurse today. The older man opened his eyes slowly, still groggy from pain medication. Morning, nurse. My wife, she want to get coffee. She's been here all night again. Sarah checked his monitors, noting that his heart rate was slightly elevated but within normal range for someone 3 days post-surgery. How's your pain level this morning? Maybe a 6. It's better than yesterday. She adjusted his pillow and checked the surgical site. Everything looked clean and properly healing. Mr. Rodriguez was one of the lucky ones. His surgery had gone smoothly, his recovery was progressing normally, and he had family support. Sarah had seen too many patients who weren't so fortunate. The doctor will be making rounds in about an hour. Is there anything you need right now? Just wondering if you could tell me about the young nurse who was here yesterday. Real quiet girl, didn't say much, but she knew her stuff. Made me feel like everything was going to be okay. Sarah paused in updating his chart. That was probably me, Mr. Rodriguez. I worked yesterday too. He squinted at her, and Sarah realized he hadn't really been looking at her face the day before. Pain medication and stress could make everything blur together. Well then, I wanted to thank you. You got good hands. Reminds me of the medics who took care of me in Vietnam. They didn't waste words either, but they knew what they were doing. Something shifted in Sarah's chest, a small warmth that she hadn't felt in weeks. Thank you, sir. That means a lot. As she left Mr. Rodriguez's room, Sarah passed the nurse's station where Jessica was now in full storytelling mode with a small audience gathered around her computer. So, I'm trying to train the new girl yesterday, right? And I'm showing her how to properly document medication administration, and she just stands there like a deer in headlights. I mean, did she even go to nursing school? Where did they find her? One of the other nurses, a young woman named Ashley who'd started just 2 months before Sarah, laughed a little too loudly. Maybe she's just nervous. Some people take longer to adjust. Nervous? Jessica's voice rose with incredulous amusement. She's been here 3 weeks. How long does it take to learn how to talk to people? I swear, sometimes I wonder if she's even qualified to be here. Sarah continued walking, but she caught the eye of Dr. Phillips, the attending cardiologist who'd been watching the exchange with obvious disapproval. Dr. Phillips was in his early 40s, a serious man who cared more about patient outcomes than hospital politics. He'd been one of the few staff members who'd actually read Sarah's resume carefully during the hiring process. Nurse Mitchell, he called out, and Sarah stopped. Could I speak with you for a moment? Sarah followed him to a quieter area near the supply closet, away from the ongoing commentary at the nurse's station. How are you finding the work here? Dr. Phillips asked, his tone professional, but not unkind. It's fine, doctor. The patients are my priority. Good. I've been reviewing your documentation and patient interactions. Your work is exemplary. He paused, glancing back toward the nurse's station. I want you to know that quality patient care is what matters here, not office politics. You're doing excellent work, and I hope you plan to stay. Thank you, sir. After Dr. Phillips left, Sarah returned to her rounds. Her next patient was Mrs. Chun, an 82-year-old woman who'd had a mild heart attack and was being monitored before discharge. Mrs. Chin's daughter was with her, a woman in her 50s who looked exhausted from worry. How was she doing today? The daughter asked as Sarah checked the monitors. Her vitals are stable. The cardiologist will want to see her before discharge, but everything looks good for her to go home this afternoon. Thank you, the daughter said, relief evident in her voice. Can I ask you something? Yesterday, the other nurses kept coming in and out, making a lot of noise, laughing about something. My mother was trying to rest, but they kept disturbing her. You're different. You actually seem to care about the patients. Sarah finished updating Mrs. Chin's chart before responding. Every patient deserves respect and quiet when they're healing. It was a simple statement, but it seemed to mean something to Mrs. Chin's daughter. Exactly. I could tell you've been doing this for a while. You have that confidence that comes with experience. If only she knew, Sarah thought. Combat medicine and civilian nursing were different worlds, but the fundamentals remain the same. Assess quickly, act decisively, and never let your personal feelings interfere with patient care. The difference was that in combat zones, Everyone understood that lives depended on professionalism. Here, some people seemed to think healthcare was a social club. The morning continued with its familiar rhythm. Sarah moved efficiently between patients, checking vitals, administering medications, updating charts, and providing the kind of quiet, competent care that patients needed but often didn't get in busy hospital environments. She spoke when spoken to, answered questions with precise information, and avoided getting drawn into the various dramas that seemed to constantly swirl around the nurse's station. Around 10:30, during a brief lull in activity, Sarah was organizing supplies in the medication room when she overheard Jessica on the phone with someone from Human Resources. "I'm just concerned about patient care," Jessica was saying, her voice carrying that false note of professional concern. "She doesn't communicate well with other staff members, she seems uncomfortable with basic procedures, and, honestly, I'm not sure she's a good fit for our team. I think maybe she'd be better suited for a different department, or maybe a different hospital altogether." Sarah continued organizing supplies, her movements steady and controlled. She'd faced hostile fire, political interference, and military bureaucracy that made hospital administration look simple. One insecure nurse with a need for attention wasn't going to make her quit a job she'd trained specifically for. What Jessica didn't know, what none of them knew, was that Sarah had recommendations from military medical officers who trusted her with the lives of special operations personnel. She'd worked in field hospitals where a single mistake could cost multiple lives, where every decision had to be perfect because there was no backup plan. She'd been selected for missions that required not just medical expertise, but the kind of mental toughness that allowed someone to perform surgery while under enemy fire. But she also knew that sometimes the best strategy was to let your opponents reveal their own weaknesses first. The rest of her shift passed without incident. Sarah provided excellent patient care, documented everything properly, and managed to avoid most of the social landmines that seemed to define the day's shift culture. As she gathered her things at the end of the day, Margaret Torres approached her. "Sarah, I wanted to apologize for what's been happening. Some people here forget that we're supposed to be professionals. I appreciate that, Margaret, but I can handle it." Margaret studied Sarah's face for a moment, and Sarah had the feeling that the older nurse was seeing something others missed. "I believe you can. But just so you know, not everyone here thinks Jessica speaks for the rest of us." Walking to her car that afternoon, Sarah reflected on her first few weeks at St. Mary's. The work itself was exactly what she'd hoped for when she decided to transition from military to civilian medicine. The patients needed skilled care, the medical challenges were interesting, and she was good at her job. The social dynamics were irritating, but manageable. What bothered her more was the realization that she was starting to care about what happened here. She'd taken this job because she needed to work, because she'd earned her nursing degree specifically to have a civilian career option. But somewhere in the last 3 weeks, between Mr. Rodriguez's gratitude and Mrs. Chen's daughter's relief and Dr. Phillips' quiet approval, she'd started to feel invested in doing more than just getting through her shifts. That evening, in her small apartment, Sarah sat at her kitchen table with a cup of tea and her laptop. She had emails from former colleagues, updates on people she'd served with, invitations to military reunions she probably wouldn't attend. There was also an email from her former commanding officer, Colonel Martinez, who checked in on her periodically. She typed a brief response, letting him know she was settling into civilian life, that the transition was going well. It wasn't entirely true, but it wasn't entirely false either. She was adjusting. She was learning to navigate a world where people seemed to think every emotion needed to be shared, every thought vocalized, every interaction turned into a performance. What she didn't mention was that she was also learning something else, that some battles were worth fighting, even when you weren't sure you wanted to win. The following Monday marked Sarah's 4th week at St. Mary's, and she could sense something different in the air as soon as she walked onto the cardiac wing. The usual morning chatter seemed more focused, more purposeful, and she noticed that several staff members who normally ignored her were now watching her with obvious curiosity. Jessica Hartwell was at the nurses' station with Ashley and 2 other nurses Sarah recognized, but hadn't officially met. They were clustered around a computer screen, and their conversation stopped abruptly when Sarah walked past. The silence felt deliberate, theatrical even, designed to make her wonder what they'd been discussing. Sarah collected her assignment for the day and began her rounds, starting with Mr. Rodriguez, who was scheduled for discharge that afternoon. His recovery had progressed smoothly, and his family was already making arrangements for home care. "Morning, Mr. Rodriguez. How are you feeling today?" "Much better, thanks to you. My daughter wanted me to ask you something." He gestured toward a woman in her 40s who was organizing his belongings. "Maria, come over here." Maria Rodriguez approached with the kind of nervous energy that suggested she'd been working up the courage to speak. "I wanted to thank you for taking such good care of my father. The other nurses, they're nice enough, but they're always rushing around, always talking. You actually listen when he tells you something hurts." "That's my job," Sarah said simply, checking Mr. Rodriguez's vital signs one final time. "Well, you're good at your job. I work at the community college in the nursing program, and I can tell the difference between someone who really knows what they're doing and someone who's just going through the motions." Sarah nodded her thanks and moved on to her next patient, but Maria's words stayed with her. It was becoming clear that while some of the staff questioned her competence, the patients and their families had no such doubts. That disconnect was interesting and potentially useful. Her next patient was a new admission, a 45-year-old construction worker named Tom Bradley, who'd had what his family kept calling a mild heart attack. Sarah reviewed his chart as she walked to his room, noting that while the heart attack itself had been relatively minor, Tom had multiple risk factors that made his long-term prognosis concerning. "Good morning, Mr. Bradley. I'm Sarah. I'll be your nurse today." Tom was sitting up in bed, looking frustrated and impatient. His wife was beside him, clearly worried despite her husband's attempts to downplay his condition. "When can I get out of here? I got a job site that needs me back by Thursday." Sarah checked his monitors and reviewed his medication schedule. "Your cardiologist will need to clear you for discharge. That decision depends on how you respond to treatment over the next day or two. It was just a little heart attack. I feel fine now." Sarah had heard this before from soldiers who insisted flesh wounds weren't serious, and from patients who thought heart attacks were like headaches, something you could just push through. But Tom's wife caught her eye, and Sarah could see the fear there. "Mr. Bradley, heart attacks, even small ones, are your heart's way of telling you that something needs to change. The good news is that we caught this early, but that also means we need to take it seriously." She spent the next few minutes explaining his medications and the importance of following up with a cardiologist after discharge. Tom listened reluctantly, but his wife asked detailed questions and took notes. Sarah could see that Mrs. Bradley understood the seriousness of the situation, even if her husband didn't. As she left Tom's room, Sarah nearly collided with Jessica, who seemed to have been waiting outside the door. "Sarah, we need to talk." Sarah followed Jessica to a small conference room typically used for family meetings. Jessica closed the door and turned to face her with an expression that suggested she thought she was about to deliver devastating news. "I've been talking to several staff members about your performance, and I'm afraid there are some serious concerns." Sarah waited, not responding to what was obviously meant to be an opening for her to defend herself. "Multiple nurses have reported that you don't communicate effectively, you seem unfamiliar with basic procedures, and you're not integrating well with the team. I've discussed this with nursing administration, and they've asked me to document these issues formally." "What specific procedures am I unfamiliar with?" Sarah asked. Jessica seemed taken aback by the direct question. "Well, for example, yesterday I observed you taking an unusually long time to set up in 4 for Mrs. Patterson." Sarah remembered Mrs. Patterson, an elderly woman with difficult veins who'd been poked multiple times by other nurses before Sarah was called in. Sarah had taken her time because she'd wanted to get the 4 placed correctly on the first try, which she had. Mrs. Patterson's veins were compromised from multiple previous attempts. I used a smaller gauge needle and took time to find the best placement. The 4 was successful and caused minimal discomfort. That's not the point. The point is that experienced nurses don't need that much time for basic procedures. Sarah realized that Jessica was either genuinely confused about what constituted good patient care, or she was deliberately mischaracterizing Sarah's work. Either way, this conversation wasn't really about nursing competence. Is there anything specific you'd like me to do differently? I think maybe you should consider whether this is the right environment for you. Sometimes people are better suited for different types of medical work. Maybe a smaller clinic or home health care, something with less pressure. Sarah studied Jessica's face, recognizing the particular satisfaction that came from believing you were delivering a crushing blow to someone you perceived as weak. It was a look she'd seen before, usually on the faces of people who confused cruelty with strength. "I'll take that under consideration," Sarah said, and left the conference room. The rest of the morning passed with a strange undercurrent of tension. Sarah noticed that other nurses were watching her more closely, and she caught fragments of conversations that stopped when she approached. Word had clearly spread that Jessica was making some kind of formal complaint, and people were choosing sides. During lunch, Sarah sat alone in the break room with a sandwich and a medical journal. She was reading an article about advances in cardiac rehabilitation when Margaret Torres joined her. "Mind if I sit?" Sarah gestured to the empty chair across from her. "I heard about Jessica's little intervention this morning," Margaret said. "I wanted you to know that not everyone agrees with her assessment of your work. I appreciate that. Can I ask you something?" Margaret's voice was careful, the tone of someone who is genuinely curious rather than gathering gossip. "You seem very comfortable with medical procedures, very confident in your assessments. But you're also very quiet about your background. Where did you work before this?" Sarah considered how much to reveal. "Military medicine. Different environment." Margaret nodded slowly. "That makes sense. I had a feeling you'd seen more serious cases than what we typically get here. Military medics usually have excellent training." "The training was thorough." "I bet it was." Margaret was quiet for a moment. "Sarah, I want you to know that Jessica doesn't speak for the cardiac wing. She's loud and she's political, but she's not necessarily representative of how most of us feel about your work." "Thank you. That's good to know. Dr. Phillips has been asking me about you. He's impressed with your patient documentation and your clinical assessments. He specifically mentioned that your notes are more detailed and accurate than most nurses provide." This was news to Sarah. She'd been focusing so much on the negative feedback that she hadn't realized her work was being positively noticed by the medical staff. That afternoon, Sarah was assigned to assist Dr. Phillips with a cardiac catheterization procedure for a new patient. The patient, a 58-year-old teacher named Linda Walsh, had been experiencing chest pain and shortness of breath for several weeks. In the catheterization lab, Sarah worked efficiently to prepare the equipment and monitor the patient's vital signs during the procedure. She anticipated Dr. Phillips' needs, provided clear updates on the patient's status, and managed potential complications before they became problematic. "Nice work today," Dr. Phillips said after the procedure was completed and Ms. Walsh had been transferred to recovery. "Your attention to detail, and there was exactly what I needed." "Thank you, doctor. Can I ask you about your previous experience? Your skill level suggests significant background in cardiac care." Sarah hesitated, then decided that Dr. Phillips had earned a more complete answer. "I worked as a combat medic and later as a surgical technician in military hospitals, trauma, and emergency cardiac care." Dr. Phillips stopped writing in the patient chart and looked at her directly. "Military medicine. That explains a lot. How long were you deployed?" 4 tours. 18 months each. "And you transitioned to civilian nursing?" "I earned my BSN while I was still active duty. Decided I wanted to continue in medical care, but in a civilian environment." Dr. Phillips nodded thoughtfully. "Well, I can see why you're so comfortable under pressure. Military medical training is typically excellent, especially for trauma care. We're lucky to have someone with your background." Walking back to the cardiac wing, Sarah felt something she hadn't experienced in weeks: professional validation. Dr. Phillips understood what her background meant, understood the level of training and experience she brought to civilian medicine. It was a reminder that not everyone at St. Mary's was focused on social dynamics over patient care. But As she approached the nurse's station, she could see that Jessica was in full storytelling mode again, this time with a larger audience that included two nurses from other departments. I'm telling you, something's not right about her. She won't talk about her background. She doesn't socialize with any of us. And when I try to help her improve her skills, she just stares at me like I'm speaking a foreign language. Ashley nodded along enthusiastically. And have you noticed how she never seems nervous or stressed about anything? I mean, I was a nervous wreck for my first month here. She acts like she's done this forever. Exactly, Jessica continued. It's not natural. Either she's hiding something about her qualifications, or she just doesn't care enough about this job to take it seriously. Sarah continued walking past them to check on her afternoon patients, but she could feel the weight of their attention. She realized that Jessica had moved beyond simply disliking her. This had become a campaign designed to make her position at St. Mary's untenable. Her last patient of the day was Mrs. Chun, who was back for a follow-up appointment after her discharge the previous week. Mrs. Chin's daughter was with her again, and they both seemed genuinely happy to see Sarah. "We requested you specifically," the daughter said. "My mother has been telling everyone about the quiet nurse who actually listened to her concerns. After all the noise and chaos during her first day, you were exactly what she needed." Mrs. Chun, whose English was limited but whose understanding was clear, patted Sarah's hand and spoke in Mandarin. Her daughter translated. "She says you have healing hands and a peaceful spirit. She wants to know if you'll be here for her next appointment." "I'll be here," Sarah said, and meant it. That evening, Sarah sat in her apartment reviewing the day's events. Jessica's campaign against her was escalating, but it was also revealing something important. The people who actually mattered, the patients, their families, and the medical staff who focus on clinical outcomes, recognized her competence and valued her contributions. The situation was becoming untenable, but not in the way Jessica intended. Sarah was realizing that she didn't just want to keep this job. She wanted to excel at it. She wanted to be part of an environment where patient care was the priority, where her skills and experience were valued, where she could use everything she'd learned in military medicine to help people in a civilian setting. But first, she was going to have to deal with Jessica Hartwell and the small group of nurses who seemed more interested in workplace drama than patient care. Sarah had handled worse situations, faced more dangerous opponents, and solved more complex problems than one insecure nurse with delusions of authority. She opened her laptop and began researching St. Mary's policies regarding workplace harassment and professional conduct. If Jessica wanted to make this into an official issue, Sarah would ensure that all relevant policies were being followed. And if Jessica wanted to question her qualifications, Sarah was prepared to provide documentation that would end that discussion permanently. Some battles were worth fighting, and Sarah was beginning to think this might be one of them. Tuesday morning arrived with an unusual level of activity on the cardiac wing. Sarah could hear the elevated voices and rapid footsteps before she even reached the nurse's station. When she turned the corner, she saw a crowd gathered around room 314, and her training immediately kicked in. Multiple people talking at once, someone crying, the unmistakable tension that preceded a medical emergency. Sarah approached the scene to find Jessica at the center of the chaos, looking frustrated and overwhelmed. Tom Bradley, the construction worker who'd been downplaying his heart attack, was sitting on the edge of his bed, sweating profusely and holding his chest. His wife was crying, and a young nurse Sarah didn't recognize was frantically checking monitors that were beeping warnings. "What's his status?" Sarah asked Dr. Phillips, who had just arrived and was trying to assess the situation. "Chest pain, shortness of breath, elevated heart rate. Started about 10 minutes ago," Dr. Phillips replied, but he was looking at Jessica for confirmation. "I gave him his morning medications like usual," Jessica said defensively. "He said he felt fine. Then he started complaining about chest pain, and now he's being dramatic about it." Sarah moved closer to Tom Bradley, noting his skin color, breathing pattern, and the specific way he was holding his chest. Something in her military trained assessment system was sending up immediate red flags. Mr. Bradley, can you describe the pain for me? It's like someone sitting on my chest, Tom gasped. Started real sudden. Feels different from yesterday. Sarah checked his pulse at his wrist, rapid and irregular. She glanced at the monitor Jessica was supposedly watching and immediately saw the problem. The EKG rhythm showed unmistakable signs of what could be developing into a serious cardiac event. Dr. Phillips, Sarah said quietly, but with enough urgency that he looked at her immediately. Look at the rhythm in leads V1 through V3. Dr. Phillips examined the monitor, and Sarah saw his expression change instantly. Give me a 12-lead EKG stat, and call the cath lab. Tell them we might have an acute MI. Jessica looked confused, but I was watching the monitor. It didn't look that bad. Sarah was already moving, gathering equipment, and preparing medications while Jessica stood frozen. Mrs. Bradley, I need you to step outside for just a moment while we take care of your husband. The next 20 minutes moved with the precise choreography that Sarah knew from emergency medicine. While Jessica fumbled with equipment and asked questions that showed she didn't understand the severity of the situation, Sarah anticipated every need, prepared every intervention, and monitored every change in Tom's condition. She started a new 4-line with the efficiency that came from years of working under pressure, drew blood for emergency lab work, and administered medications exactly as Dr. Phillips ordered. When the 12-lead EKG confirmed that Tom was having another heart attack, this one more serious than his first, Sarah had already prepared the equipment needed for emergency intervention. We need to get him to the cath lab immediately, Dr. Phillips announced. This is a STEMI. Time is critical. Sarah helped transfer Tom to the transport gurney, continuing to monitor his vital signs and providing reassurance to both Tom and his terrified wife. During the transfer, she noticed that Dr. Phillips was watching her work with something that looked like professional appreciation. In the cardiac catheterization lab, Sarah assisted with the emergency procedure to open Tom's blocked coronary artery. Her hands moved with the steady precision that came from working in field hospitals where hesitation could cost lives. She anticipated complications before they occurred, provided exactly the right equipment at exactly the right moment, and maintained perfect sterile technique throughout the procedure. Excellent work, Dr. Phillips said quietly as they completed the successful intervention. Your response time in there may have saved his life. Tom Bradley was stable and recovering, but the incident had created ripples throughout the cardiac wing that would take time to settle. Sarah returned to her other patients, but she could feel the change in atmosphere. Word had spread about what had happened in room 314, and people were talking. She was checking on Mrs. Patterson, the elderly woman with difficult veins, when she overheard a conversation in the hallway between two nurses from the day shift. I heard Jessica completely missed the signs. The new girl, the quiet one, she's the one who spotted it. Jessica's saying it wasn't that serious, that everyone's overreacting. Dr. Phillips told the charge nurse that the new girl's assessment skills probably prevented a fatality. That doesn't sound like overreacting to me. Sarah focused on Mrs. Patterson's care, but the old woman had been watching her face during the overheard conversation. That was either talking about, wasn't it, dear? You helped save someone today. Just doing my job, Mrs. Patterson. Well, you're very good at your job. I can tell the difference. Some of these nurses, they're nice enough, but they don't really see you, if you know what I mean. You see people. During lunch, Sarah found herself sitting with Margaret Torres and two other nurses she'd worked with but hadn't gotten to know well. The conversation naturally turned to the morning's emergency. I have to ask, said Linda, a nurse who'd been at St. Mary's for about 5 years. How did you spot that rhythm change so quickly? I was looking at the same monitor and didn't see anything alarming. Sarah considered how much to explain. The T-wave inversions in the anterior leads combined with his symptoms and the timing since his initial MI. It suggested acute progression. Have you seen a lot of cardiac emergencies? Margaret asked. Some. Different settings, but similar presentations. Linda nodded thoughtfully. Well, however, you learned it. I'm glad you were there today. Jessica was completely overwhelmed. That afternoon, Sarah was restocking supplies when Jessica appeared beside her with an expression that suggested she'd been building up to this conversation. I want to talk about what happened this morning. Sarah continued organizing medication supplies. What about it? You made me look incompetent in front of Dr. Phillips. Sarah paused in her work and looked at Jessica directly. I didn't make you look anything. I responded to a patient emergency. You could have said something to me privately instead of going directly to the doctor. Mr. Bradley was having a heart attack. There wasn't time for private conversations. Jessica's face flushed with obvious frustration. That's exactly the kind of attitude I'm talking about. You think you know better than everyone else. You don't respect the chain of command, and you make the rest of us look bad. Sarah set down the supplies she was holding and gave Jessica her full attention. Jessica, I think we need to be very clear about something. Patient care is my priority. When someone is having a cardiac event, my job is to respond immediately and appropriately. If you think that makes you look bad, that's something you need to address with your own skills and training, not with me. Don't talk to me about skills and training. I've been doing this job for 3 years. You've been here a month. Yes, you've been doing this job for 3 years. This morning, during a cardiac emergency, you missed obvious EKG changes, you delayed appropriate interventions, and you characterized a STEMI as a patient being dramatic. That's not about tenure, Jessica. That's about competence. Sarah had spoken quietly, but her words carried the weight of absolute certainty. Jessica stared at her as if seeing her clearly for the first time. You can't talk to me like that. I just did. Jessica left without another word, but Sarah could see in her expression that this confrontation had changed something fundamental. Jessica had been treating her like someone who would be intimidated by workplace politics and personal attacks. She was beginning to understand that she'd miscalculated. The rest of the afternoon passed without incident, but Sarah could sense a different energy on the floor. People were looking at her differently, speaking to her with more respect, including her in conversations she'd been excluded from before. Word had spread not just about the emergency itself, but about how she'd handled both the medical crisis and Jessica's subsequent confrontation. Near the end of her shift, Dr. Phillips asked to speak with her privately. I wanted to follow up on this morning's events, he said, closing the office door. Your clinical assessment was exceptional. You identified acute changes that could have been missed, and your response time was exactly what the situation required. Thank you, doctor. I also want to address something else. I'm aware that there have been some concerns raised about your integration with the nursing staff. After observing your work today and reviewing your performance over the past month, I can tell you that those concerns are not shared by the medical staff. Dr. Phillips paused, seeming to choose his words carefully. Sarah, I've worked with military medics before. I recognize the level of training and experience you bring to this position. I also recognize that sometimes civilian healthcare environments can be challenging for people transitioning from military medicine, but not for the reasons some people think. How do you mean? Military medical training emphasizes competence, efficiency, and patient outcomes above all else. Sometimes civilian environments place more emphasis on social integration and following established hierarchies, even when those hierarchies don't serve patient care. That can create conflicts. Sarah understood exactly what he was saying. Yes, sir, it can. I want you to know that from a medical perspective, your work here has been exemplary. Your clinical skills, your documentation, your patient interactions, all excellent. I hope you'll continue working here because we need nurses who prioritize patient care the way you do. Walking to her car that evening, Sarah reflected on how much had changed in a single day. The emergency with Tom Bradley had forced her to reveal capabilities she'd been keeping in reserve, but it had also clarified something important about her role at St. Mary's. She wasn't just another nurse trying to fit into an established social structure. She was a medical professional with specialized training and experience, and when lives were on the line, those qualifications mattered more than workplace politics. People like Dr. Phillips understood that. Patients like Tom Bradley benefited from it, and nurses like Jessica would have to adapt to it. That evening, Sarah's phone rang while she was making dinner. The number was familiar, but unexpected. Her former commanding officer, Colonel Martinez. "Sarah, I hope I'm not calling at a bad time." "No, sir. Good to hear from you. I want to check in on how the transition is going. Last time we spoke, you mentioned some adjustment challenges at the hospital." Sarah considered how to answer. A month ago, she might have downplayed the situation, characterized it as minor workplace drama. But today's events had shifted her perspective. "It's been interesting, sir. Some challenges with staff dynamics, but the medical work is exactly what I hoped for." Staff dynamics can be tricky when you're coming from our environment. People don't always understand what military medical training means. That's becoming clear. Well, I have some news that might interest you. I just spoke with Dr. Patricia Hendricks at Walter Reed. She's developing a new program to integrate military medical personnel into civilian healthcare systems. She's looking for people with your background to help design training protocols and mentorship programs. Sarah felt a flicker of interest. "What kind of program?" "Partnerships with civilian hospitals to provide specialized training for trauma response, emergency protocols, that kind of thing. It would be part-time consulting work, but it might be exactly the kind of bridge between military and civilian medicine that could benefit both sides." "That sounds promising. Think about it. Dr. Hendricks will be in touch if you're interested." "And Sarah, whatever challenges you're facing at that hospital, remember that your training and experience are assets, not problems to be hidden." After the call ended, Sarah sat in her quiet apartment thinking about Colonel Martinez's words. For weeks, she'd been trying to minimize her background, to blend in, to avoid drawing attention to the ways her experience differed from traditional civilian nursing paths. But today had shown her something important. When it really mattered, when lives were on the line, her training and experience weren't just valuable, they were essential. Tom Bradley was alive tonight because she'd recognized signs that others had missed, because she'd responded with the speed and precision that came from years of emergency medicine in the most demanding environments possible. Jessica Hartwell might want to make this about workplace social dynamics, but Sarah was beginning to understand that this was really about something much larger. Whether St. Mary's Hospital wanted to be the kind of place that prioritized competence and patient outcomes, or the kind of place where personal politics mattered more than medical excellence. And if they wanted to make that choice, Sarah was prepared to help them make it clearly. The Wednesday following Tom Bradley's emergency brought an unexpected visitor to the cardiac wing. Sarah was reviewing patient charts at the nurse's station when she noticed a woman in a business suit speaking quietly with Dr. Phillips. The woman was carrying a tablet and taking notes, which immediately suggested some kind of administrative investigation. Margaret Torres approached Sarah with a knowing look. "That's Linda Chun from Quality Assurance. She's here about yesterday's incident with Mr. Bradley." Sarah nodded, continuing her chart review, but she was aware that Linda Chun had been observing the cardiac wing for the past hour, speaking with various staff members and reviewing documentation. It was exactly the kind of thorough investigation she'd expect after a significant patient event. Around 10:30, Linda Chun approached Sarah directly. "Nurse Mitchell, I'm Linda Chun from Quality Assurance. Could I speak with you about yesterday's incident with Mr. Bradley?" They moved to the same conference room where Jessica had attempted to intimidate Sarah just days earlier. Linda Chun had a calm, professional demeanor that suggested someone who was accustomed to gathering facts rather than making judgments. "I'm reviewing the sequence of events that led to Mr. Bradley's emergency intervention yesterday. Can you walk me through your observations and actions?" Sarah provided a clear, chronological account of her assessment of Tom Bradley's condition, her identification of concerning changes in his EKG rhythm, and her communication with Dr. Phillips about the need for immediate intervention. She spoke with the precision that came from years of giving medical briefings where accuracy could mean the difference between mission success and catastrophe. "You identified concerning rhythm changes that other staff members had not noticed. Can you explain how you recognize these changes?" The T-wave inversions in leads V1 through V3, combined with his clinical symptoms and the timing since his initial myocardial infarction, indicated possible acute anterior wall involvement. This pattern suggested the need for immediate cardiac catheterization. Linda Chun made notes on her tablet. How would you characterize the response time from identification of the problem to implementation of appropriate interventions? Appropriate. Dr. Phillips responded immediately when I brought the rhythm changes to his attention. The delay was minimal. What do you think might have happened if these rhythm changes had not been identified when they were? Sarah considered her answer carefully. Mr. Bradley was experiencing acute coronary syndrome progression. Without immediate intervention, he was at significant risk for a larger myocardial infarction, potentially with fatal outcomes. Linda Chin nodded and made more notes. One final question. In your professional opinion, was this emergency preventable with different monitoring or assessment protocols? The emergency itself wasn't preventable. Mr. Bradley had multiple risk factors, and his initial presentation indicated ongoing cardiac instability. But early recognition and rapid response protocols prevented what could have been a much worse outcome. After the interview, Sarah returned to her patient care duties, but she couldn't help noticing that Linda Chun was now speaking with Jessica Hartwell. Through the conference room's glass wall, she could see that Jessica appeared agitated and defensive, gesturing frequently and speaking rapidly. During lunch, Margaret filled in some details about the quality assurance investigation. They're reviewing whether our monitoring protocols need to be updated and whether additional training is needed for recognizing acute cardiac events. That makes sense after what happened, Sarah said. It also makes sense because this is the third cardiac emergency this year where initial symptoms were either missed or misinterpreted by nursing staff. The hospital is concerned about liability issues. This was new information to Sarah. 3 incidents. Jessica was involved in at least one of the previous cases. In June, an elderly patient complained of chest discomfort that Jessica attributed to anxiety. The patient had a heart attack 6 hours later. It wasn't clear whether earlier intervention would have made a difference, but the family filed a complaint. Sarah was beginning to understand that yesterday's incident wasn't just about one emergency. It was part of a larger pattern that hospital administration was taking seriously. That afternoon, Dr. Phillips asked Sarah to assist with a complex case. A 62-year-old woman named Patricia Williams who was experiencing unusual symptoms following cardiac bypass surgery. Ms. Williams had been complaining of persistent fatigue and occasional dizziness, but her standard cardiac markers were normal. Her symptoms don't match typical post-surgical complications, Dr. Phillips explained as they reviewed her chart. But something's not right. I want a fresh perspective. Sarah spent time with Patricia Williams, taking a detailed history and conducting a thorough assessment. Ms. Williams was articulate and thoughtful about her symptoms, and something in her description reminded Sarah of cases she'd seen in military hospitals. Dr. Phillips, could this be related to medication interactions? She's on several new prescriptions since surgery, and some of these combinations can cause the fatigue and dizziness she's describing. They reviewed Ms. Williams' medication list together, and Dr. Phillips identified a potential interaction between her cardiac medications and a sleep aid she'd been prescribed by another doctor. Good catch, Dr. Phillips said as they adjusted her medication regimen. I should have looked at that more carefully. Sometimes the obvious answer is hiding in plain sight. Ms. Williams' symptoms improved dramatically within 24 hours of the medication adjustment, confirming Sarah's assessment. But more importantly, the case demonstrated something that Dr. Phillips mentioned to Linda Chun during her continued investigation. Thursday morning brought another development in what was becoming a more comprehensive review of the cardiac wing's protocols and personnel. Sarah arrived to find that Jessica was not at work, and Ashley was visibly nervous about something. "Where's Jessica today?" Margaret asked Ashley during the morning shift report. "She called in sick," Ashley replied, but her tone suggested there was more to the story. Dr. Phillips arrived for rounds with Linda Chun beside him, and Sarah realized that the quality assurance investigation had expanded beyond the single incident with Tom Bradley. "We're implementing some changes to our monitoring and assessment protocols," Dr. Phillips announced to the nursing staff. Linda will be observing our procedures for the rest of the week to ensure we're identifying potential problems before they become emergencies. Over the next several hours, Sarah watched Linda Chun observe various nurses during routine patient care. She timed response to patient complaints, reviewed documentation practices, and asked detailed questions about assessment procedures. Around midday, Linda Chun asked Sarah to demonstrate proper EKG interpretation for a patient who was experiencing chest discomfort. Sarah walked through her assessment process, explaining how she identified normal versus concerning rhythms, what clinical symptoms correlated with specific EKG changes, and how to prioritize interventions based on severity. That's exactly the kind of systematic approach we're looking for, Linda Chun said afterward. Your assessment protocol is very thorough. Thank you. It becomes automatic with practice. Can I ask about your training background? Your approach suggests specialized education in cardiac assessment. Sarah provided a brief overview of her military medical training, including her experience with emergency cardiac care in field hospitals and trauma centers. Linda Chun took detailed notes and asked several follow-up questions about the specific protocols she learned. That explains a lot about your clinical skills. Military medical training is typically very advanced, especially for emergency response. Friday brought news that clarified the entire week's events. Jessica Hartwell had been placed on administrative leave pending a comprehensive review of her clinical performance. The review had been triggered by the incident with Tom Bradley, but had expanded to include several other cases where her assessment and response protocols had been questioned. Sarah learned this from Dr. Phillips during a brief conversation after they'd successfully treated another patient emergency. This time, Sarah had identified early signs of fluid retention that could have led to congestive heart failure if left untreated. I want you to know that the quality assurance investigation found your clinical performance exemplary, Dr. Phillips said. Linda Chun specifically recommended that your assessment and monitoring protocols be used as the standard for training other nurses. I appreciate that feedback. There's something else. The hospital is developing a new position, Emergency Response Coordinator for the cardiac wing. The position would involve training other nurses in advanced assessment techniques, developing protocols for early identification of cardiac events, and serving as a clinical resource for complex cases. Sarah felt a surge of interest. That sounds like interesting work. It would be a significant promotion with supervisory responsibilities and specialized pay scale. I recommended you for the position based on your clinical skills and your ability to respond effectively under pressure. Thank you, Dr. Phillips. I'd be very interested in that opportunity. The job offer represented everything Sarah had hoped for when she transitioned from military to civilian medicine. Challenging work that utilized her specialized training, the opportunity to improve patient outcomes, and recognition for competence rather than politics. That afternoon, Sarah received a phone call from Dr. Patricia Hendricks at Walter Reed. Dr. Hendricks had received Sarah's contact information from Colonel Martinez and wanted to discuss the program for integrating military medical personnel into civilian health care. I've heard excellent things about your work at St. Mary's, Dr. Hendricks said. Colonel Martinez tells me you've been navigating the transition from military to civilian medicine very successfully. It's been a learning experience. I'd like to offer you a consulting position with our new program. We're developing training protocols to help military medical personnel transition to civilian health care, and we're also creating partnerships with civilian hospitals to improve their trauma and emergency response capabilities. The consulting work will be part-time and flexible, designed to complement her civilian nursing position. It would involve developing training materials, conducting workshops, and serving as a liaison between military medical programs and civilian hospitals. St. Mary's Hospital has expressed interest in participating in our pilot program. Dr. Hendricks continued, your position there would make you an ideal coordinator for that partnership. By the end of the week, Sarah's situation had changed completely. Jessica's campaign against her had backfired spectacularly, resulting in a comprehensive investigation that highlighted Sarah's exceptional clinical skills. Instead of being pushed out of St. Mary's, she was being offered a promotion that would utilize her specialized training and provide opportunities for professional growth. More importantly, she found her place in civilian medicine. The emergency response coordinator position would allow her to do what she did best: assess critical situations quickly, respond effectively under pressure, and train others to provide excellent patient care. That evening, Sarah called Colonel Martinez to update him on recent developments. "Sounds like you've found your footing," he said after she described the promotion offer and the consulting opportunity. "It took a while to understand how to navigate civilian workplace dynamics, but I think I'm getting there." "Sarah, you've never had a problem with workplace dynamics. You've always had a problem with people who prioritize politics over competence. The difference is that now you're in an environment where competence eventually wins." That's a good way to put it. Just remember that your training and experience aren't something to hide or apologize for. They're assets that make you better at your job. The right people will recognize that, and the wrong people will eventually eliminate themselves from the equation. As Sarah prepared for her weekend, she reflected on the events of the past week. Jessica's attempt to undermine her had instead revealed the stark difference between political maneuvering and professional competence. When lives were on the line, when emergencies required immediate response, when clinical skills determined patient outcomes, all the workplace drama and personality conflicts faded into irrelevance. Tom Bradley was alive and recovering because Sarah had identified signs that others missed. Patricia Williams was feeling better because Sarah had looked beyond obvious explanations to find the real cause of her symptoms. The cardiac wing was implementing new protocols because Sarah's approach to patient assessment had proven more effective than existing practices. She found more than just a job at St. Mary's Hospital. She'd found a way to use everything she'd learned in military medicine to make a difference in civilian healthcare. And she was just getting started. 3 months later, Sarah had settled into her role as emergency response coordinator for St. Mary's Cardiac Wing with a quiet efficiency that had become her trademark. The promotion had brought new responsibilities, training other nurses in advanced assessment techniques, developing protocols for early identification of cardiac events, and serving as a clinical resource for complex cases. Her office was small but functional, decorated only with her nursing certifications and a single photograph of her military unit. The consulting work with Dr. Hendricks' program had proven equally rewarding. Sarah spent 2 days a month at various hospitals, teaching emergency response protocols and helping military veterans transition into civilian healthcare roles. The work felt like a natural bridge between her past and present, allowing her to honor her military service while building her civilian career. Jessica Hartwell had never returned to St. Mary's after her administrative leave. The investigation had revealed a pattern of missed assessments and inadequate documentation that extended back more than a year. She'd been quietly transferred to a less demanding position at another facility, where her preference for workplace politics over patient care would presumably cause less potential harm. On a crisp February morning, Sarah was conducting a training session for new nurses when her phone buzzed with an emergency alert. Mass casualty incident at the harbor, multiple trauma victims incoming, all available medical personnel requested to report immediately. Sarah's military training kicked in automatically as she read the details. A construction accident involving a partially collapsed crane had injured at least 12 workers, with several in critical condition. "Training session is suspended," Sarah announced to the group of new nurses. "We have incoming trauma patients. Follow standard mass casualty protocols and report to your assigned supervisors." The next few hours moved with the controlled chaos that Sarah remembered from field hospitals in Afghanistan. Ambulances arrived in steady succession, each carrying construction workers with injuries ranging from minor lacerations to severe trauma. Sarah coordinated the nursing response, ensuring that patients were triaged appropriately and that critical cases received immediate attention. One patient, brought in by the 3rd ambulance, immediately caught Sarah's attention. The paramedics were working on a man in his early 30s who had been trapped under debris for over an hour. His injuries were severe, multiple fractures, internal bleeding, and what appeared to be significant crush trauma to his lower extremities. What's his status? Sarah asked the lead paramedic as they transferred him to Trauma Bay 2. Lost consciousness at the scene, blood pressure dropping, possible internal bleeding. We've got 2 large-bore IVs running, and he's had 2 units of O-negative. Sarah assessed the patient quickly, noting his skin color, breathing pattern, and the way his body was positioned to protect injured areas. Something about his posture and the small tattoo visible on his wrist suggested military training. Dr. Phillips, this patient needs immediate surgical intervention, Sarah called out as she reviewed his preliminary assessment. Possible splenic injury, definite orthopedic trauma, and signs of shock. Dr. Phillips arrived immediately and began his own assessment. Good eye. Get him prepped for surgery and call orthopedics. We're going to need multiple specialists for this one. As Sarah worked to prepare the patient for emergency surgery, she noticed something that made her pause. Despite his unconscious state, the patient's left hand was positioned in a specific way that Sarah recognized, a hand signal used by special operations personnel to indicate medical emergency. It was subtle enough that civilian medical staff would never notice it, but unmistakable to someone with Sarah's background. She checked his dog tags, which confirmed her suspicion. Marcus Torres, Navy SEAL, currently on active duty. The emergency contact information listed a commanding officer at Naval Special Warfare Command. During the brief window while the patient was being prepped for surgery, Sarah made a decision that would have surprised her former colleagues at St. Mary's. She called the emergency contact number on Marcus Torres' dog tags. Naval Special Warfare Command. This is Commander Patterson. Commander, this is Sarah Mitchell, Emergency Response Coordinator at St. Mary's Hospital. I have Chief Petty Officer Marcus Torres in critical condition following a civilian construction accident. He's going into emergency surgery for multiple trauma, and I thought his unit should be notified. Chief Torres? He's supposed to be on leave. How bad is it? Sarah provided a professional assessment of Marcus Torres' condition and the planned surgical interventions. Commander Patterson listened without interruption, then asked several specific questions about his injuries and prognosis. Ms. Mitchell, can I ask about your background? You're giving me the kind of detailed medical briefing I'd expect from a military medic. I'm a former military medic, sir, for deployments with Navy SEAL units. There was a pause on the line. What unit? Various assignments, sir. Most recently with Team 7 in Afghanistan. Team 7. Were you part of Operation Neptune Dawn? Sarah felt a familiar tightness in her chest. Operation Neptune Dawn had been one of her most difficult missions, a rescue operation in hostile territory where she'd spent 36 hours providing medical care to wounded SEALs while under enemy fire. It wasn't something she talked about, even with other veterans. Yes, sir. Sarah Mitchell. I remember your name from the after-action reports. You saved the lives of 4 Team 7 members during that operation. I was doing my job, sir. Well, you did it exceptionally well. Chief Torres is lucky to have someone with your experience taking care of him. I'm going to notify his team, and we'll have someone there as soon as possible. Yes, sir. And Sarah, thank you for what you did then, and for what you're doing now. The surgery on Marcus Torres lasted 4 hours. Sarah coordinated his post-operative care and monitored his recovery closely, using the specialized protocols she developed for critical trauma patients. His injuries were severe, but the surgical team had been able to repair the internal bleeding and stabilize his fractures. Around 6 o'clock that evening, as Sarah was updating Marcus Torres' chart, she heard something that made her look up from her work. The distinctive sound of helicopter rotors approaching the hospital. Living near a major medical center, helicopter medical transports were common, but this sound was different, heavier, more purposeful, definitely military. Sarah walked to the window and saw a Navy helicopter settling onto the hospital's helipad. It wasn't a medical transport. It was a personnel carrier, the kind used for rapid deployment of special operations teams. As she watched, 4 men in Navy uniforms exited the helicopter and walked toward the hospital entrance. 20 minutes later, Sarah was approached by a hospital administrator she'd never seen before. Ms. Mitchell, there are some Navy personnel here who asked to speak with you specifically. They're in conference room A. Sarah found the four men waiting for her, and she immediately recognized the bearing and demeanor of active duty SEALs. The senior officer, a commander with graying hair and intense eyes, stood when she entered. Ms. Mitchell, I'm Commander Richardson, Team 7. We came as soon as we heard about Chief Torres. How is he, Doc? Asked one of the younger men, whose casual use of her old military nickname suggested he'd been briefed on her background. He's stable. The surgery went well, but his recovery will take time. Multiple fractures, but no permanent damage to vital organs. He was very fortunate. Commander Richardson nodded. We'd like to see him if possible. But first, I wanted to thank you personally. Commander Patterson filled me in on your service record. You saved the lives of several of my men during Operation Neptune Dawn. Sarah felt the familiar weight of military protocol and camaraderie. They were good sailors, sir. Worth saving. They were. And they're all still alive and serving because of your skills and dedication. Commander Richardson paused. I also want you to know that Chief Torres wasn't on leave from an accident. He was on leave because he was considering transitioning to civilian life. Said he was having trouble figuring out how his military skills would translate to civilian careers. Sarah understood the implication. That's a common challenge for military medical personnel. It is. But seeing what you've accomplished here, how you've used your military training to excel in civilian medicine, that might give him some perspective on his options. The men spent the next hour visiting with Marcus Torres, who had regained consciousness and was coherent despite his pain medication. Sarah observed the reunion with the professional detachment she'd maintained during countless similar scenes in military hospitals. But she couldn't help being moved by the obvious affection and respect these men had for each other. As the Navy personnel prepared to leave, Commander Richardson approached Sarah one final time. Ms. Mitchell, I want you to know that your name still comes up in our briefings. The medical protocols you developed during your deployments are still being used to train new medics. Your service made a difference, and it continues to make a difference. Thank you, sir. That means a lot. If you ever decide you want to return to military medicine, either active duty or as a civilian contractor, you'd have recommendations from every SEAL team you ever served with. I appreciate that, sir, but I'm happy with civilian medicine. I've found ways to use my military training that feel meaningful. Commander Richardson smiled. I can see that. This hospital is lucky to have you. As the Navy helicopter lifted off into the evening sky, Sarah reflected on the unexpected turn her day had taken. The mass casualty incident had reminded her why she'd chosen emergency medicine, the satisfaction of using her skills to save lives when it mattered most. The reunion with her military past had reinforced her pride in her service and her continued connection to the military medical community. But most importantly, the day had demonstrated something she'd been learning gradually over the past few months. Her identity wasn't divided between military and civilian medicine. She was the same person, using the same skills, driven by the same commitment to excellent patient care, whether she was treating wounded soldiers in Afghanistan or construction workers in a civilian hospital. Word of the Navy helicopter and Sarah's connection to the visiting SEALs spread throughout St. Mary's Hospital by the next morning. The story grew with each telling, but the essential facts remained true. The quiet nurse who'd been dismissed and underestimated by some of her colleagues had been personally thanked by Navy Special Operations personnel for her military service and her continued excellence in civilian medicine. Dr. Phillips found Sarah in her office the next morning, reviewing patient files with her usual focused efficiency. I heard we had some distinguished visitors yesterday. Yes, sir. They came to check on their injured team member. And to thank you for your military service, for what I understand. Sarah nodded, but didn't elaborate. Sarah, I've known since you started here that you had significant military medical experience. What I didn't fully appreciate was the level of respect you'd earned from the special operations community. I was good at my job, sir. Same as I try to be here. You're much more than good at your job. You're exceptional at your job, and yesterday reminded everyone here of the level of training and experience you bring to civilian medicine. Dr. Phillips paused, seeming to choose his words carefully. I wanted you to know that the hospital administration has been discussing creating additional positions similar to yours at other facilities in the health system. Emergency response coordinators for each major department, using the protocols and training methods you've developed. That sounds like a good initiative. They've asked if you'd be interested in overseeing the development of this program system-wide. It would be a significant promotion with authority over emergency response protocols at multiple hospitals. Sarah considered the offer. It represented exactly the kind of career growth she'd hoped for, the opportunity to use her specialized skills on a larger scale to improve emergency medical care throughout the health system. I'd be very interested in that opportunity. 6 months later, Sarah stood in the main conference room at St. Mary's Hospital, addressing a group of nurses, doctors, and administrators from hospitals throughout the region. She was presenting the emergency response protocols that had been developed based on her military medical training, adapted for civilian healthcare environments. The program had been remarkably successful. Emergency response times had improved dramatically. Early identification of critical conditions had increased patient survival rates, and the training methods had been adopted by hospitals in 3 states. Marcus Torres, fully recovered from his injuries, had decided to transition to civilian life and was now working as an emergency medical technician while pursuing his nursing degree. He credited Sarah with showing him how military medical training could translate into meaningful civilian healthcare careers. Dr. Patricia Hendricks' integration program had expanded beyond its original scope, establishing partnerships between military medical programs and civilian hospitals throughout the country. Sarah's position as a liaison between these two worlds had become a full-time role, one that allowed her to honor her military service while building something new in civilian medicine. As Sarah concluded her presentation, she reflected on the journey that had brought her to this moment. She'd started at St. Mary's as a quiet nurse, trying to blend in, trying to hide her military background, try to avoid the kind of attention that had once been focused on survival in hostile environments. But she'd learned something important. Excellence couldn't be hidden indefinitely. Competence had a way of revealing itself, especially in situations where lives were on the line. The skills that had made her an exceptional combat medic, quick assessment, decisive action, grace under pressure, commitment to mission success, were exactly the skills that made her an exceptional civilian nurse. The people who'd mattered most, patients, their families, medical colleagues focused on patient outcomes, had recognized her capabilities from the beginning. The people who'd focused on workplace politics and social hierarchy had eventually been forced to acknowledge what had been obvious all along. Sarah Mitchell was exactly the kind of medical professional any hospital would be fortunate to have. Jessica Hartwell's campaign to undermine her had backfired completely, revealing more about Jessica's insecurities and professional limitations than about Sarah's qualifications. In trying to diminish Sarah's reputation, Jessica had instead highlighted the stark contrast between political maneuvering and professional excellence. Sarah had never needed to prove herself to people like Jessica. She'd already proven herself to Navy SEALs under enemy fire, to military commanders who trusted her with their most critical missions, to patients who depended on her skills for their survival. The validation that mattered had been earned years ago in far more demanding circumstances than anything civilian medicine could present. The Navy helicopter that had arrived to honor one of their wounded had also served as a powerful reminder to everyone at St. Mary's Hospital. The quiet nurse they'd underestimated was someone who'd earned the respect of the most elite military units in the world. Her colleagues' opinions about her social skills or workplace integration seemed rather trivial in comparison to personal thanks from Navy SEAL commanders. As Sarah gathered her materials after the presentation, Dr. Phillips approached her with a smile. Excellent presentation. I think you've convinced everyone here that military medical personnel bring exceptional value to civilian health care. Thank you, sir. It's been rewarding work. Any regrets about the transition from military to civilian medicine? Sarah considered the question as she looked around the conference room, filled with medical professionals who were excited about implementing new protocols that would save lives, improve patient outcomes, and advance emergency medical care. No regrets, sir. This is exactly where I belong. And for the first time since she'd walked through the doors of St. Mary's Hospital, Sarah Mitchell was absolutely certain that was true.